Welcome, dear students and our faculty today, Dr. Aravind, Dr. Suvarna, and Dr. Sreevidya, and Dr. Saneesh, for the preparatory class, the last one for the OLYMPIAD 2025, which the Indian College of Anesthesiologists is hosting. In fact, this is the first time that any college has started this program, an initiative for you students to grade yourself among your peers. So this is a very interesting platform where you can see and you can come to know how you're faring. You've attended the 3 preparatory classes and today is the final one. Of course, the exam will be on the 6th of April and we are of course going to wish you all the best. And in this last preparatory class, if you have any doubts, you can always clarify them. For you all to know about the Indian College of Anesthesiologists, whom many of you have heard, some may not have heard, you must know that this college is completely an academic body. It's a trust which is formed by very senior faculty of anesthesia of our country and abroad. And we formed this academic body which deals only with the academic promotion of our dear students. You've heard of the webinars. All of you have heard of the consecutive webinars that we've been holding for the last 5 years. And now we have almost going to complete 2 centuries, more than 200. We have done 270 webinars consecutively. We have an ICA PG assembly, and this year it's going to be held in Delhi on the 25th of April at the UCMS. If you go onto our website, you can still register for it. This is a very interesting interactive PG assembly where you will be able to interact with the examiners. So that's very important. And we also have our journals. So this is the PG assembly which you must go through onto the website. We have our ICA Con, and we'll be holding the 15th National and the 5th International Conference in Jodhpur in the end of August. All details are available on our website. We have a very popular yearbook of anesthesia, and these topics that are covered here are very well appreciated by the faculty and the students. We have a journal, the JICA, which is the Journal of Indian College of Anesthesiologists, free online journal. Again, it can be accessed very easily. We have many fellowships. Have you seen it on the ad just now? We have fellowships in thoracic anesthesia, cardiac anesthesia, liver transplant, oncoanesthesia, regional anesthesia, palliative care, to name a few. And here you have to apply to the institutions. And of course, after a selection, you can join as a fellow. So students, it's very, very important for you to know that we, Indian College of Anesthesia, also has a very good collaboration with the American Society of Anesthesia, as well as the SAMBA, that is the Society of Ambulatory Anesthesia, USA. And we have an exchange program with them where students can actually apply for research as well. So please go ahead, go onto our website and see all the available matter that is there. So today, let's come to our final preparatory class, and we wish you all the best. Thank you, Saneesh. You may start.
Thanks very much, ma'am. At the outset, I would like to introduce our National Dean of Indian College of Anesthesiologists, Dr. Muralidhar Kanchi, to our audience. Sir, please have a few words to our audience, students.
Thank you, Dr. Saneesh. I'm really delighted to be a part of this program. It's being wonderfully conducted and it is becoming very successful and popular. I think we should pat you on the back for that. Thank you so much. As already pointed out by Dr. Jayashree Sood, we have a very popular program, the ICA webinars every Wednesday, the Yearbook of Anesthesiology, the journal, JICA, and various fellowship programs. And Dr. Jayashri also highlighted the collaborative societies, the American Society of Anesthesiology, the Samba, etc. And the future looks bright. And thank you, Sanish, for arranging this final preparatory class for the ultimates, which is going to happen early next month. Thank you so much. And congratulations, and look forward to having many more such sessions in the forthcoming months and years. Thank you so much. And I will be there till the end of the program. Thank you.
Thank you very much, sir. I think this is also an opportunity to remind the youngsters that Indian College of Anesthesiologists do take an initiative to do what is called as PG mentoring program. Last two national conferences, we had 1 month sessions, and it's going to be a continuous program. So eventually we are helping the youngsters to seek higher and higher positions in the specialty. So before beginning our session number 4, preparatory session, I would like to thank all the faculty who contributed to the preparatory classes. I'm very thankful to Dr. Abhyuday Kumar from AIMS Patna, Dr. Rashmi Salotra from UCMS, Dr. Ananda Padmanabhan from KMCT Calicut. Of course, Dr. Aravind Narayanan is here with us today from Chennai. Dr. Suvarna is joining. She's from Calicut again. Dr. Sreevidya from Trivandrum. So we had a new set of young faculty. We were actually attempting to cover the entire syllabus, but covering the entire syllabus of MD or DNB is not possible. But we have practically covered most of the topics with an aim to introduce you to the type of questions and strategy to arrive at the answers. Last sessions, we had also included our technical partner to explain how you will be joining the actual online exam platform from the comfort of your home or study room or library, whatever. It should be a quiet place. You should be taking the exam all alone, because your webcam and the microphone will be on throughout, and your full screen is going to be shared, and it will be recorded for any dispute clearance. Okay, so you need to listen to the proctors. Any doubt, you can take their help for technical things, but otherwise, exams you'll be taking on your own. There will be positive marks. Correct answer is going to fetch you 4 marks, but wrong response will take away -1 mark again. And multiple response questions, we have already explained what exactly is the partial scoring. So let's get started. Again, I can't proceed without thanking the top leadership of ICA, right from the President, Dr. Jayashree Sood, Chief Patron, Dr. B. Radhakrishnan, our CEO, Dr. Baljit Singh, National Dean, Dr. Muralidhar Kanchi, International Dean, Dr. Kumar Belani, our ICA yearbook editor, Dr. Mukul Kapoor, and our editor of JICA, Journal of Indian College of Anesthesiology, Dr. Kirti. Thanks very much. Let's start with today's session. I think I'll hand over the session to Dr. Aravind to start the proceedings. So this is day 4 of our preparatory class. Over to Dr. Aravind.
Yeah, very good evening and welcome. Let's jump right in, because we have not the expanse of the subject matter as Dr. Saneesh has mentioned, but we need to go through the different types of questions and just orient you to what you would need to be thinking when you take up the questions, and what kind of a thought process should come into your mind when you select the choices. I guess Dr. Saneesh had mentioned earlier also that you can always keep some questions for review, and then you can visit them later. So the technical aspects have been covered in the previous session. So we are trying to have a gist of topics this time. Let's see whether we are able to tread all of them. I welcome Dr. Sreevidya and Dr. Suvarna also. So we will start off. Dr. Saneesh, is that okay with the first question? So section A appears to be the single best. So it's not nomenclature which is important, but read the instructions. It means single best choice. You have 4 choices, A, B, C, or D. So the first question goes like this: the period of vulnerability after 3 courses of bleomycin for testicular cancer. A question from oncology. I guess most of you would know what it is, but just think and give the best answer for this. Shall we start the timer now?
One change here is our Zoom poll window will mention only A, B, C, D. You need to read the questions from the slides.
Okay, so should I read the question again or the choices too?
Yeah.
Yeah. So the question is, the period of vulnerability after 3 courses of bleomycin for testicular cancer is: choice A will be 1 month, choice B is 1 year, choice C says lifelong, and choice D says no vulnerability with just 3 courses. So think about it. I think we have about 30 seconds. The timer system might be different for your exams because it's not going to be based on single question, but this is a single best answer. Would you, the options A, B, C, or D, you need to pick up as I've read to you earlier.
Today's Zoom poll window will be just a voting pad. I think those who have joined through mobile devices might have some difficulty. But if you are using your laptop or desktop or even tab, you can keep away the poll window and read the answers again from the slides. Okay? We'll check the results.
All right, so I think 47% of you have chosen option B. But the correct answer in this case has been chosen by 23% of you only, which says lifelong. Yep, there is a lot of doubt about bleomycin, but it causes nucleotide damage. And there are different reports which talk about the amount of doses. As the dose escalates, the damage is more. However, even with 2 or 3 courses, we see that patient might have lifelong problems. Only about 5 to 10% develop pulmonary toxicity, but they do have it for life, and they can come at any point of time with X-ray findings and so on. So you need to keep it in mind, especially patients coming with treatment of lymphoma and testicular tumors. So the answer choice C would be the correct answer in this case. So we go to the next question, which says, during correction of scoliosis, SSEP monitoring is employed. An increase in somatosensory evoked potential monitoring latency and a decrease in amplitude could be explained by each of the following except. So it's imperative that you read the entire question and don't jump to the choices A, B, C, or D immediately, because the mentioned word except is an important keyword here. So please read through the choices. First choice A is anterior spinal artery syndrome. B says propofol infusion. C says hypotension. And choice D is 2 MAC of isoflurane anesthesia. So you need to make a choice except. So SSEP monitoring in all these cases is reduced except. So you have the poll window here. If you want, you can go back, switch over, and then read the question again. So in which of these situations, which choice would the amplitude of the monitor and the latency period be reduced?
I can find diversified responses. Okay.
All right, so you need to examine the choices and find out. And 40% of you have chosen option B. I'm surprised. Option B, C, and D. So we need to go back and think SSEP, think about neuromonitoring if you've done scoliosis cases. In which of these situations, which of these choices, neither B, C, or D? The answer is except. So option A says anterior spinal. Anterior spinal artery is not for sensory, right? It's for motor. So immediately it should trigger in your mind that anything to do with the anterior part will not actually affect the somatosensory evoked potentials. It will affect only the motor evoked potentials. So that option A is the best answer in this case. So we'll move on to the next question, Saneesh. Third question says hypoglycemia is more likely to occur in the diabetic surgical patient with which of the following comorbid diseases? So again, think it's hypoglycemia in a diabetic with which of these comorbid diseases? Is it A, renal disease, B, rheumatoid arthritis with high dose steroids, C, COPD with terbutaline and aminophil treatment, or is it manic depressive disorder treated with lithium? So you have 4 choices here. Which of these would actually predispose a diabetic patient to hypoglycemia?
Dr. Brinda had raised hands. Would you like to talk? I'm allowing your microphone. Okay, Dr. Brinda, you want to raise any point?
As a part of this preparatory session, we have tried to address diverse questions. Certain questions do have contentious answers. There could be an interpretation issue in some of the questions, and you're welcome. But this discussion is not about the subject matter as such. It's about the type of the questions. And we are trying to expose you to varying degrees of difficulty of questions, both in terms of interpretation and in terms of how you perceive the question. Am I right, Saneesh?
Yes, exactly.
So the answer in most of this, I think 41% of you have chosen option C, COPD with, I think any of the beta 2 agonists, you're going to use them, they're going to increase the sympathetic outflow, and the hyperglycemia will be the possibility. And steroids, I'm sure hyperglycemia happens with steroids. So here the question is about hypoglycemia. So anything to do with a metabolism defect of insulin, meaning compromise of renal metabolism of insulin, and that can increase the circulating insulin levels, leading to hypoglycemia. So all diabetics, hyperglycemia is not always a situation. You always have to think about the mechanism. So some questions can be twisted. It's up to you to think. We're exposing you to this kind of a questioning session. So please read it carefully and go back and check. It's only a single best, so you don't have to bother yourself much, but do exclude those which are obvious. Anything with prednisolone is obvious. Terbutaline inhaler is obvious, so don't fall into that trap. All right, let's go to question number 4. Electroconvulsive therapy, ECT, is recognized treatment modality in cases of severe or medication-resistant depression. So that's the STEM. So regarding ECT, which one do you think is the right choice? A, an initial tachycardia and rise in blood pressure is common. B, propofol is the preferred induction agent as it allows the longest seizure duration. C, etomidate is contraindicated as an induction agent as it raises the seizure threshold. And D, an increased dose of dexamethasone may be required in cachectic patients. So which of these 4 choices do you think would be most appropriate with respect to the STEM, which is electroconvulsive therapy? It's important to read the stem of the question and in your mind analyze each of the choices. In this case, which is the best fit, which would occur? Since there is no word called except, so you need to process the information on the question and then address the 4 choices which are given to you. A good technique is to exclude the most obvious ones which you know are wrong. And you might end up with just 2 to balance and figure out which of these 2 are the best fit. In the actual exam, I guess, Dr. Saneesh, they would, before they submit, they can always go back and check or keep some questions for review, especially those with a longer stem and a long 2 or 3 sentences of choices. So always be careful with these questions. Read them again and again. So you may like to keep these as for addressing later. So do we have the poll results for these?
Okay.
Oh, surprising. Only 6% have got the correct answer. 42% have said tachycardia. I'm sure all of you know when you administer ECT, the first response is the bradycardic response. And then there is tachycardia. And then 20 to 30% of you all have said about option B and C. But option B and C, you should realize propofol, is it the best agent? Etomidate, is it contraindicated? No, etomidate actually gives a longer seizure time. So option A, B, C are wrong. Option D is the correct answer because you need a higher dose of scolin or dexamethasone. So don't just immediately discard an answer. I think most of you have jumped at the hemodynamics and the propofol etomidate, that they are distractors. So we need you to condition you to think about it and don't discard any answer, examine each of them in their merit. So to go on to the next question. A 72-year-old lady comes to the pain management clinic. She complains of 2 months of right-sided facial pain below the eye. She describes the pain as stabbing, but brief and severe, and it's provoked by light touch to the skin. Which of the following would be an appropriate first line in her management? So read the stem carefully. Which of the following is the first line in her management? So the option A says acyclovir, option B says carbamazepine, option C says gabapentin, and option D talks about 0.075% capsaicin cream. So you need to think about what exactly are you looking at, what is the diagnosis, and what would be the first line of management. So it's, don't jump to an answer immediately. Please examine all the 4 answers. It's possible during the exam that you may not even know what this whole question is about. The suggestion would be not to attempt it. Leave it aside, mark it for review, come back to it at the end. Maybe you will have some clues somewhere in the question paper, and then you may your brain may just kick it to action and you may start thinking about it. And Dr. Saneesh, would you recommend that if they absolutely have no clue about the question, should they attempt it at all?
Yeah.
Is guesswork a good idea?
Better not to lose the hard-earned points.
Yes,
but actually, it happens like some other questions might give some clue to this one. So that is also possible. So keep cool, read through the next questions. Who knows, you might get a clue somewhere.
The syllabus is quite vast, as Dr. Saneesh has pointed out earlier, and there are a lot of esoteric or very vague areas of anesthetic practice which can also be accessed during our questions. So I think in this case, 43% of the respondents have said option C. And what is option C? Shall we go to the options again, Saneesh, because I have them a little jumbled?
Okay.
Yes, option C is gabapentin. Come on, gabapentin will not be the first line of management. It's very clear it is trigeminal neuralgia and stabbing pain with light touch, carbamazepine. Carbamazepine is an anti-epileptic agent, but it is the first line of management. Acyclovir is only for post-herpetic neuralgia, not for the pain. So option B would be the right answer. 37% of you have actually addressed it correctly.
So we need to concentrate on keywords like first line, the best treatment, next step, those kind of words. We need to be very
something like short acting, something like immediate action, something like long acting treatment. I think all those words do matter in the decision, the choices when they're close by. The choices are all close by. You need to be careful. Is this question 6? Is Dr. Suvarna or Sreevidya taking it?
Am I audible?
Yes. Please go ahead. This is Dr. Suvarna. Welcome to this platform.
Thank you, Saneesh, for including me. First time I'm joining with the ICA team. Okay. So the question, straight away going to the question. The 6th question is, branches of cervical plexus are all except. You should be conscious about the question except. Option A, greater auricular. Option B, lesser occipital. Option C, transverse cervical. Option D, lesser auricular. It's a single best response question. We can start answering. Always read the questions and be careful about the except.
Question might take you to the first year of MBBS, but right now, what you tick is what matters. Okay, 30 seconds more than enough for that.
Option D is the responded by 71% of the candidate. Can I go back to the response? Choices. Yes, that is a lesser auricular. That is the correct answer. So most of you have answered correctly. Go to the next question. Neuropraxia, all are false except. Option A, endoneurium is damaged. Option B, has conduction block. Option C, axonal discontinuity is present. And D is, it needs surgical repair. Here also you should be careful about the double negative. It's false except. Only one option is true. Okay, 40% answered it correctly. Option D, that is, it has conduction block only. Actually, neuropraxia is the mildest form of nerve injury in which there is only conduction block. It doesn't need surgical repair. Usually, it automatically get corrected, means by remyelination occurs within weeks or months. So the correct response is conduction block. It has only conduction block.
If I may come in, Dr. Suvarna, I got feedback from some of the PGs who attended this earlier that they said we should not be giving confusing questions like double negatives, not use except. I agree that most of the medical colleges we refrain from framing such questions, but I think in this scenario we are looking at OLYMPIAD. It's an Olympiad, and we are looking at higher level of thinking and processing power. So I guess we should put them under the microscope and scanner and make them think critically. So these questions are not to confuse, it's to appeal to their higher level of thought process. I think we should continue, but maybe we'll try to filter it out to not have too much of confusion. Saneesh, do you agree with us?
Correct. Basically, this is an elimination test. It's
Perfect.
infinite
Perfect. Yeah.
knowledge.
So they cannot script that it is very difficult. It is meant to be difficult.
Yes, correct.
Please, let's continue. Thank you.
I told you, no, I am first time I am joining the ICA team. So the next question, 8th question is serratus anterior plane block target all except option A, long thoracic nerve, option B, axillary nerve, option C, thoracodorsal nerve, option D, lateral cutaneous branches of intercostal nerve. I think it will be easy for you, this question. Most of you must be giving the serratus block for the breast surgeries and other anterior chest wall surgeries. The result, yes, 63% is chosen option D. That is the option. Can I go back to it? It's the axillary nerve. That's the correct answer. So we'll go to the next question. 9th question is safe level of injection pressure during nerve block is. This everyone should know. Option A is less than 15 psi. Option B is less than 20. Option C is less than 25. Option D is more than 15. This we should know. Okay, 38% is chosen the correct response as less than 15 psi. That is the correct. You should always check the injection pressure level. What resistance you are getting while injecting the anesthetic agent. So it should be less than 15 psi. Shall we go to the next question? Yes. 10th question is major benefits of epidural analgesia in upper abdominal surgeries like a major surgery like Whipple procedure include all except. Option A, it decreases incidence of postoperative atelectasis. Option B, it leads to earlier return of GI function. Option C, it decreases the risk of urinary retention. Option D, it reduces the risk of pulmonary embolism and DVT. You can start answering now. I think it's quite easy. All of you are familiar with the epidural analgesia. All of you must be using it for all major surgeries. 59% chosen the correct response of option C, that it doesn't decrease any urinary retention. Actually, it can cause. So decreased risk of urinary retention. Option C is the correct response. It is again an except. That is a problem here. I think Dr. It is Sreevidya.
Yeah.
Sreevidya, please.
A few more single best response questions are there. So question number 11, which of the following is the most likely cause of increased incidence of right ventricular failure in patients with morbid obesity? Option A, chronic hypoxia. Option B, chronic silent pulmonary aspiration. Option C, chronic silent subendocardial ischemia. Option D, increased pulmonary blood flow. Most likely cause of right ventricular failure in morbid obese. Your time starts now.
Nowadays, intensive care anesthesia and in fact all the specialty we need to cater to morbid obesity. So this is an intensive care question, right? From critical care.
Yes. Yes. The response, please.
Okay, 30 seconds. Fine. Feel free to put your answers. I think there is some uniformity trend. We'll see whether that uniformity
Very
is good enough.
Yeah. 59% of people have answered it correct. Is due to chronic hypoxia. How does chronic hypoxia produce right ventricular failure? It is due to hypoxia-induced pulmonary vasoconstriction. This chronic hypoxia produces pulmonary artery constriction, increasing the pulmonary vascular resistance. This leads to pulmonary hypertension, which produces more strain on the right ventricle. Right ventricle initially hypertrophies to cope with this increased workload. Over time, it dilates, weakens, and resulting in right heart failure. So the answer is chronic hypoxia. Coming to question number 12. Which of the following is the most likely cause of a decrease in end-tidal carbon dioxide tension during general anesthesia with constant minute ventilation? So the keywords are decrease in end-tidal carbon dioxide tension during general anesthesia with constant minute ventilation. Okay. Option A, administration of sodium bicarbonate. Option B, decrease in cardiac output. Option C, decrease in fresh gas flow in vein circuit. Option D, malfunction of inspiratory valve in circle system. Okay. Decrease in EtCO2 with constant minute ventilation.
In an objective type examination for each and every question, you need to keep your focus because there is 4 marks to gain from each question, but you are risking 1 mark if you go wrong. So spend your time intelligently, efficiently.
Very good. 65% of people have answered correctly, and the answer is option B, decreased cardiac output. How does decrease in cardiac output decrease EtCO2? Because in general anesthesia, the EtCO2 reflects the balance between carbon dioxide production and elimination. So a decrease in cardiac output reduces the pulmonary blood flow, limiting the amount of carbon dioxide delivered to the lungs for exhalation. This results in lower EtCO2 despite constant ventilation. So the answer is decrease in cardiac output. Next question. So this is from communication part. So which type of communication is most effective during an emergency in the operating room? Option A, indirect and polite suggestion. Option B, clear, direct and closed loop communication. Option C, silent gestures and signals. Option D, lengthy explanation of the problem. So in a busy, in the operating room, in an emergency, how should you communicate?
We can see a great uniformity in the response. Because communication skills is something that we emphasize in the present curriculum. The leadership quality, multidisciplinary approach, and the communication skills.
Very good. 97% has answered it correctly. That is clear, direct, and closed loop communication. So especially in the era of artificial intelligence, what we can do is the clear communication with the patient and relatives. So what is meant by clear communication? That is speaking simple, unambiguous language to avoid misunderstanding. Like instead of saying, can you handle it? Say, please give 50 microgram of fentanyl. Be clear. But it matters in a noisy, fast-paced operating room. Vague instructions can lead to error. What is meant by direct communication? Address the right person directly and ensure they know you are speaking to them. Instead of saying somebody check the blood pressure, we can ask, Nurse Alex, please check the blood pressure now. It matters because it avoids confusion when multiple people are present in the operating room. And in closed loop communication means the receiver speaks back the instructor to confirm understanding, and the sender confirms the reply is correct. So the answer is clear, direct, and closed loop communication. So this is from the quality indices that has been practiced in anesthesia. So what is a quality indicator related to anesthesia-related complication? Quality indicator for complication. Option A, time from induction to incision. Option B, incidence of unplanned ICU admission. Option C, number of surgeons per room. Option D, length of the surgical procedure. The quality indicator related to anesthesia-related complication. Find the single best answer.
To take this opportunity to suggest to all the postgraduates, even during your postgraduation itself, be involved in the quality control activities in your institution, because you will learn a few things that you may not learn only through the clinical practice. because ultimately patient is more important.
Very good. Most of them answered correctly. So it is the in unplanned ICU admission. Incidence of unplanned ICU admissions shows the anesthesia-related complication incident. So what is unplanned ICU admission? It signals something went wrong. Like it can be respiratory failure, cardiovascular instability, or delayed recovery from anesthesia or adverse drug reactions. So this reflects not only the system performance in the hospital, and not on, but it also represents the anesthetic management, preoperative preparation, intraoperative monitoring, or postoperative handover quality. So by taking the audit of the unplanned ICU admissions, we can check whether the system performance is good or not. Next question is from artificial intelligence. Which AI tool is used to detect real-time patient deterioration during surgery? A. Generative adversarial networks. B. Convolutional neural networks. C. Predictive analytic models. D. Reinforcement learning agents. Should be real-time patient deterioration during surgery. I know most of us are not familiar with the artificial intelligence in anesthesia, but still it is coming into our practice. So we should know what are the tools that are available.
Definitely, artificial intelligence forms an important part of the present curriculum. So those who think artificial intelligence might take away your job, remember that the more you humanize, more you stress on communication skills, you can't be replaced. So artificial intelligence is going to come in your practice, but the role you can define.
Oh, so I can see most of them has answered correctly, even though we are not familiar. From the name itself, we can see that it is predictive analytic model. So what is predictive analytic model? They use historical and real-time data to forecast future events, like detecting when the patient might deteriorate during surgery. So it collects the data like from the vital signs like heart rate, BP, SpO2, carbon dioxide level, etc. Then the pattern is recognized or trend is recognized. Like if there is fall in oxygen or rise in heart rate variability, it shows impending hemodynamic instability or respiratory failure. Then it predicts the risk based on these patterns. And it will also give alerts and recommendations. So it sends an alert or recommend to the anesthesia team, ensuring timely action. What has to be done, like adjusting IV fluid, medication, or ventilation. So that is predictive analytic model.
Yeah. Now we move to the world of multiple response type questions, where we'll be having the partial scoring system. Again, to repeat our partial scoring system, suppose 2 out of 4 are correct. Each of the correct response will carry 2 marks, and each of the wrong response will take away half mark each. So that's the way. So if you pick up 2 correct answers, you get 2 plus 2, 4. But unfortunately, you tick one of the wrong answers, you lose 0.5 marks. So you'll end up getting 3.5. If you put only the correct answer, only one, and select the 2 wrong response, so 2 minus 0.5 and minus 0.5, which you will end up getting only 1 mark. Suppose there are 3 correct answers and 1 wrong response. Each correct answer will give you 1.33 marks. So if you happen to tick 2 correct responses out of the 3, you will get 2.67 marks. But if you happen to tick the wrong one, you will lose 1 mark. So this is the way. So we'll go to our first multiple response type question.
Multiple response question 1 is, when would you consider a patient on these drugs an appropriate candidate for central neuraxial block? Option A, the last dose of ticlopidine taken 14 days back. Option B, the last dose of apixaban 12 hours back. Option C, the last dose of eptifibatide 8 hours back. Option D, last dose of clopidogrel 3 days back. So in which of these cases you will consider central neuraxial block is appropriate? You can start polling.
So the fact is, there may be only one response. There can be two responses correct. There can be three, or there can be all four correct. All combinations are possible. So evaluate option by option.
Yes. So the answer, how do I, option A is answered by 80%. Option B by 52. Actually, the answers of ticloprid option A and option C are correct. For apsiximab, it is 24 to 48 hours is the correct time. And clopidogrel, anyway, you will be knowing. So the two correct responses are option A, clopidogrel last is 14 days and Eptifet for a time period of 8 hours is advised. So A and C are the correct response. Next, second question is, the treatment of local anesthetic systemic toxicity include A, intravenous adrenaline as per ACLS protocol. Option B, administer intralipid as a bolus followed by infusion early. Option C, support airway with 100% oxygen. Option D, no change in epidural infusion if local anesthetic if it is going in a low concentration. You can start answering now. Read the choices well and answer. Option A is answered by 63% and B by 94%. That is the best treatment. That is intralipid as a bolus followed by infusion as should be started as early as possible. And option C is also correct. That is start supporting the airway with 100% oxygen. And the most catchy answer is the intravenous adrenaline. It should be not as per the ACLS protocol. Rather, you require a smaller dose only. And in case of arrhythmias and all, you should avoid calcium channel blockers, beta blockers, all those things. That you should be very careful. That treatment means the resuscitation is quite different from the standard ACLS protocol. That is the catchy answer here. Next question, please. The sciatic nerve blockade provides sensory loss of option A, posterior thigh, option B, medial and posterior thigh, option C, medial leg below the knee, option D, most of the leg below knee except medial aspect. You should be aware of the cutaneous distribution of the lower leg when you give a nerve block. So read the options carefully and answer. That can be single or multiple response correct.
If you want to read the options again, you can minimize the poll window and take it back later.
Okay, option A is answered by 55%. That is posterior thigh. That is correct response. Option B is wrong. Option C. Again, it is the option D that is the correct. That is most of the leg except the medial aspect. Actually, the leg medial aspect is supplied by the saphenous nerve, which is a branch of femoral nerve. So that you should be careful when you give popliteal block and all. The medial aspect is covered, the leg is covered by the medial leg below the knee is covered by saphenous nerve, which is a branch of femoral nerve. Posterior thigh and most of the leg except the medial aspect is supplied by sensory distribution is by the sciatic nerve. So A and B are the correct responses.
Yeah, moving on to the next question. Can I come in? Yeah.
Yes, please.
So we have seen the past few questions that we have addressed either anatomical facts or straightforward thought process about newer techniques, and some of them are clinical thought processes which you need to have. But sometimes you will have these questions like this, which is sort of unusual, and they are given there only for some of you to just pick your brains and then to see whether you can answer it. But they are a part of the process of thought, but most of it is actually factual. If you know it, you know it. If you don't know, there's no way you can discern it. Let's go to this question. Regarding patients with myotonic dystrophy and their perioperative management. Option A says myotonic dystrophy is inherited in an autosomal dominant pattern. Option B says prolonged muscle relaxation can be precipitated by the use of non-depolarizing muscle relaxants. Option C says reversal of non-depolarizing muscle relaxants using neostigmine is recommended. And option D, troublesome muscle spasm may be alleviated by using phenytoin 3 to 5 milligram per kg intravenously. Questions of this pattern are sometimes designed to confuse your thought process. If you feel that it is some topic which you don't know, it's wise not to attempt it. Keep it aside. But some of you might know about it in detail. And this question is, many times these type of questions are distractors to spoil your time management strategy. We want you to waste more time on this. Don't fall into the trap. Some unusual esoteric questions are better left alone. I'm not trying to discourage those who are very good at rare diseases, and some of you might have handled such cases. But the questions and the choices are also unusual. So here the choice A and choice D, if you have answered both of them, only then you get the full marks. So B and C are wrong. They are not. So I see the 91% of you have answered. So that's exactly what was the point we are trying to make. That what appears very obvious and it's a very unusual disease, most of you may not know about it, it's better left alone rather than lose marks over it. Shall we move to the next one? Question 5. A 29-year-old patient is listed for open reduction lateral fixation of the wrist. He asks about the possibility of surgery under local anesthetic and a brachial plexus block is planned. The following is true about the anatomy of the brachial plexus. So sometimes you will have a long question which you may think it's about a clinical question, but it may be taking you to a stem which ends and then you are asked about anatomy. Still, it's the realm of brachial plexus blockade. So the choices are A, ulnar nerve is a branch of the lateral cord. B, median nerve receives supply from both the medial and lateral cord. C, the radial nerve has no sensory supply in the arm. D, the suprascapular nerve is a branch of the upper trunk. So it's primarily an anatomy question. However, it has been placed under a clinical stem. So these questions are also distractors. So watch out if you feel that you cannot think so much, it's confusing you. Leave them aside and come back to review. And you have to analyze each and every choice repeatedly. And only then you might actually get the correct combination of answers which you need. Some of them will be very obvious. So I would suggest you keep a pencil or a pen or something and then you mark and then try to judge which is the best fit. Is it option A and option B and option C and option D? So this section B is going to be a challenge.
Yeah, Dr. Aravind, like our technical expert was explaining, there is a notepad-like feature in the examination platform. So rather than having physical paper and pen, we can note it on the screen.
So will they not be allowed to use paper and pen? Is that how the system goes?
No, that's okay, but that should not be something like looking at a textbook or something.
Yep, I think
everybody will be under
instruction.
Scanner. So they are offered a notepad like window.
Okay.
Through the exam panel, not a window outside. Within the exam platform itself, they are allowing one rough note. So it's a notepad kind of thing.
Okay, I think these questions would require them to use it because all four choices have to be analyzed and assessed, and it's going to be time consuming. You need to have a mechanism to do it.
Yeah. Why I mentioned is when they take the mock exam section, they need to be familiar with this also, the notepad facility, along with the examination.
Yeah, and we don't want to distract them or give them the wrong kind of direction. So I think paper pen is not what we would use, but something on similar lines to note down your thought processes and mark each option A, B, C, whether they can fit or not.
Yeah.
So in fact, actually here, 87%, more than 80% have opted for choice B and choice D, which is good. Actually, choice C is also right, but option A is wrong. So I think sometimes it's easier to exclude what is obviously wrong, and then you examine the others. Ulnar nerve, lateral cord, come on, it's a medial. So you think about it like that. Okay. Then go to the next question, question number 6. Again, a clinical question. During an elective orthopedic operating list, a patient is scheduled to have an Achilles tendon repair, and the patient has been placed in the prone position. Complications directly from prone positioning include choice A, compartment syndrome, choice B, hypotension, choice C, visual loss, and choice D, neuropraxia. Again, it's important to point out that these choices, complications are not for exactly this procedure. The procedure is given just for you to have a thought process. But read procedure of this kind, in this kind of positioning, what are the complications which can be expected. You need to assess, read the question and fit each of the choices and decide whether they fit or not. If you have a doubt, keep them separately, reanalyze, reassess. If you're excluding something, obviously exclude them, and that becomes easier. That's how these questions have to be answered. So if you feel compartment syndrome, yes, can happen, tick it. If you feel hypotension can happen or have a doubt, reassess. Visual loss, prone, maybe yes. Neuropraxia, positioning issues, if you don't do adequate padding. So think like that one by one and try fitting them. So you may find all four are correct, and then you go back and check, no, one of them doesn't fit that well. So these questions are designed to make you think from a multitude viewpoints and fit all the choices, and some of the choices are very close. So some of you might argue, okay, option A, compartment syndrome, yes, you can think of abdominal compartment, you can think of compressive neuropathy, you can think of visual loss, but hypotension, some of you might argue hypotension might happen, yes, but if you do adequate padding, may not. So the question is, hypotension can also happen in supine position. So positioning per se leading to, so answers here are A, C and D, and they are pertinent to prone positioning. So it's always good to think about the question which has been given as a clinical stem and then try to fit the answers to it. Move on to the next question, which is question 7. Is Dr. Suvarna taking it or Dr. Sreevidya?
Yeah. Can I come in?
Absolutely. Yeah.
Okay. Question number 7 is, which of the following conditions can cause sudden onset pulmonary edema? Select all that apply. A. Rapid re-expansion of lungs following pneumothorax. B. Oxygen toxicity. C. Rupture of the mitral papillary muscle. D. Severe preeclampsia. So what all conditions can cause sudden onset pulmonary edema? So all of them have answered, almost all the options are equal. Option D and A have answered by most. Except option B, A, C and D are correct. Even though these three conditions can cause pulmonary edema, the pathophysiology is different. As in re-expansion pulmonary edema, sudden lung reinflation causes negative intrathoracic pressure, which drives the fluid shift into the alveoli, leading to pulmonary edema. Whereas in rupture of the mitral papillary muscle, which occurs with acute myocardial infarction, this papillary muscle rupture causes acute myocardial infarction and blood flow back into the left atrium produces pulmonary edema. And in severe preeclampsia, hypertension can cause pulmonary edema, or it can be due to endothelial damage, which increases the vascular permeability, fluid leakage into the alveoli, and can cause pulmonary edema. So these three conditions can cause, except oxygen toxicity, can cause pulmonary edema. So the answers are A, C, and D. Next question. So which of the following interventions are part of the initial management of sepsis in ICU? Select all that apply. Option A, administer broad spectrum antibiotics within 1 hour after sending for blood culture and sensitivity. Option B, start vasopressors immediately before fluid resuscitation. Option C, measure lactate level to assess tissue perfusion. And option D, use norepinephrine as the first line of vasopressor if mean arterial pressure is less than 85 millimeter mercury after fluids. So you have to choose the correct answer.
Again, reminding, if the Zoom poll window is obstructing the view of the slide, you can minimize it, read the options, and then click on the choice. Feel free to click on your choice because it's anonymous. Only you'll be knowing whether you got it right or not. It's only a practice session. Our idea is to give you some clues how to approach these questions, because the objective type examination like our ICA OLYMPIAD definitely will test out the depth of knowledge, of course the coverage as well. So it's a competitive examination.
Okay. Option A is answered by 89%. That is correct. Option C is answered by 93%. Both are correct. So we will see what is wrong with B and D. So the B says start vasopressors immediately before fluid resuscitation. That is incorrect because fluid resuscitation is the first line management in sepsis. the guideline says administer 30 ml per kilogram of IV crystalloid fluid before initiating vasopressor. And in the option D, the vasopressor of choice is norepinephrine. That is correct. But it is only started if the hypotension with a mean arterial pressure less than 65, not 85 millimeters mercury, persists after fluids. So the option A and C are correct, and B and D are incorrect. Coming to the next question, what are the predictors of successful extubation? That is the critical care question. Option A, a 2-hour spontaneous breathing trial is a more sensitive predictor of successful extubation than 30 minutes spontaneous breathing trial. Option B, rapid shadow breathing index of more than 105 during SBT predicts successful extubation. Option C, increased age increases the risk of failed extubation. Option D, failed extubation is more likely in patients with upper airway abnormalities. So you have to choose the correct options. Okay, 92% have answered it correctly. Like option C is correct. So old age increases, decreases the successful extubation, and 62% answered option D. That is also correct. So we'll see what is wrong with option A. Option A shows, okay. So why increased age? Option C. Why increased age increases risk of failed extubation? Because age is a in aged patients, older patients have weakened respiratory muscles, other comorbidities, and decreased lung compliance that make them difficult to extubate. But in option A, the spontaneous breathing trial, the 30 minutes trial and the 2-hour trial are equally effective. That nothing, one is not better than the other. That is why the option A is incorrect. 2-hour spontaneous breathing trial is equally sensitive predictor of successful extubation than a 30-minute spontaneous breathing trial. And the option B, shallow breathing index of less than 105, not more than 105 during SBT predicts successful extubation. So the answers are option C and D.
We move to section C. Section C, again, reminding you, it's assertion, reason type. 2 statements, 1 assertion statement, 1 reason statement. Check whether both are correct. And if both are correct, whether reason statement explains assertion or assertion is correct, reason is wrong, assertion is wrong, reason statement is correct. So these are the 4 options. The options will remain the same. So we'll try to put the options in the section C as 1, 2, 3, 4. But don't bother about whether it is A, B, C, D or 1, 2, 3, 4. You just need to click on that tick button. That's all. So no confusion should be there. We try to explain the strategy. So first question, who is taking?
Yeah, I will take.
Okay. Fine.
The assertion is a 50-year-old woman who develops stridor 10 hours after thyroidectomy should be treated with calcium chloride. And the reason, stridor after thyroidectomy can result from hypocalcemia due to parathyroid injury or devascularization leading to laryngospasm, which can be reversed by correcting calcium level. So option A, both assertion and reason are correct, and the reason is the correct explanation of assertion A. Option B, both assertion and reason are correct statement, but reason is not the correct explanation for assertion A. In option C, assertion is correct, but reason is incorrect. And D, assertion is incorrect, but reason is correct. Very good. 54% of the delegates have answered as option A. That is the correct answer. So the catch points are 10 hours after the thyroidectomy. So immediately after thyroidectomy, it can be hematoma, or any postoperative edema, or tracheal injury, or recurrent laryngeal palsy. Here the catch point is 10 hours after thyroidectomy can be caused by hypocalcemia, which is typically due to, so that is the assertion. And the reason is, it is typically due to parathyroid injury or devascularization, and calcium chloride is used to correct hypocalcemia to relieve the laryngospasm. So in here, the assertion and reason are correct, and the reason is the correct explanation for assertion A. So coming to the next question, assertion is positive end expiratory pressure or PEEP improves oxygenation in patients with acute respiratory distress syndrome. And reason, PEEP increases the intrathoracic pressure, which reduces the venous return to the heart and may lower cardiac output. So in option A, both the assertion and reason are correct, and reason is the correct explanation for assertion A. Option B, assertion and reason are correct, but reason is not the correct explanation. And C, assertion is correct, reason is wrong. D, assertion is incorrect, reason is correct. All please. Very good. 89% of the people have answered it correctly. So even though both statements are correct, the reason doesn't explain the assertion. So the assertion says PEEP helps to keep the alveoli open at the end of exhalation, which prevents the alveolar collapse and improves gas exchange. This leads to improved oxygenation, especially in patients with ARDS. And the reason says PEEP does increase intrathoracic pressure, which can reduce venous return to the heart, thereby potentially lowering the cardiac output. PEEP primarily works by preventing alveolar collapse and improving the gas exchange, not by the effect on cardiac output. So both the statements are correct, but the assertion is not explained by the reason. So the answer is D.
Third question is, assertion is to test the accidental intrathecal or intravenous placement. An epidural test dose of 3 ml lignocaine with adrenaline in a concentration of 5 microgram per ml is given as a bolus. Reason, in accidental intrathecal placement of epidural catheter, epidural test dose will cause high spine. So you read the assertion and reason and see whether both are correct and whether the reason correctly explain or not the assertion.
It's very important to remember that there will be 5 questions of this kind, and all the options A, B, C, D will remain the same for all 5 questions. You can save time.
That's why I didn't read it. So only thing is you read the assertion reason and first you see whether both are correct and whether the reason correctly explain the assertion. That is the real trick. Yes, 60% is done it correctly. That is, assertion is correct, but the reason is incorrect statement. Rather, with an epidural test dose, if it is an accidental intrathecal placement, the test dose will cause a low spinal block only. It doesn't cause high spinal. Next question. Assertion is a curvilinear USG probe are best for quadratus lumborum block. Reason is high frequency probes give best resolution of deeper structures. So you read the assertion and reason and can start answering now whether the reason correctly explained and whether both are correct also. We must be very commonly using the ultrasound probes these days, both the curvilinear and linear probes you are using. So you should know this. It's a basic question. Only 42% is answered correctly. Option C. Actually, for quadratus QL block, you require a curvilinear probe because it's a deep block. But the high frequency probes are the linear probes which give best resolution of superficial structures. So for deeper structures, you require a curvilinear probe. High frequency probes are the linear probes. So assertion is correct, but the reason is wrong. Next question.
Continuing with regional anesthesia, going to the next question, which is question 5. During an ankle block, if nerve stimulator is used, it's mainly for the locating the posterior tibial nerve, which can be difficult to anesthetize in small volumes of anesthesia. So as we saw the previous questions, the stems of these assertions and reasons are long statements. So do read them carefully, but the choices remain the same 4. So that's an advantage. Examine each of the assertion and the reason statement independently. If both of them are right, your choices are between A and B. If one of them is wrong, your choices now go to C and D. So it's easy to analyze it in this manner. Please read the question again and think what would be the correct answer. Even if one of them is wrong, A and B are out. You exclude A and B choices, or the first 2 choices. You go to the second and the third and the fourth choice. So this becomes an easy pattern for you to think. but you still have to read the two statements first independently, check whether they are right, and if they are right, you need to also match whether the reason is the actual reason for the first statement. We have only about 40 attendees today. I think most of you have got the hang of how things are in the past 3 preparatory sessions. So in this case, about 63% of you have answered option C, which is the right answer. It's good that you all are getting the hang of this whole assertion reason thing. If they look confusing to start with, yes, the assertion is correct, but the reason is an incorrect statement because posterior tibial nerve causes flexion. So the moment you know something is wrong, you jump to C or D options, and then you analyze again, which is right, which is wrong. Once either of them is wrong, there's no question of one acting as a reason for the other, and so on. So we go to the next question, which is question 6. Ropivacaine, levobupivacaine show reduced neurotoxicity and cardiotoxicity. The moment I read it, I know assertion is right. The reason part is what is tricky over here. So read the reason and think. So I've given you the answer. Assertion is correct. But you need to think about the reason. Is it a right statement? In which case your choices are between A and B. If it is wrong, your choice actually is straight away C. So you think about it and analyze it like this. Here, these questions do examine your factual knowledge base and also how you critically integrate your knowledge to your clinical things. So now the question is, A is correct, perfect. So it's either A or C. But is B also right or is it wrong? So the reason in this case, let's see the answers, then we'll go ahead. Most of you have actually opted for the wrong answer. That's because I think it's quite a technical term that was used over there. Yes, local, which are chiral drugs, they are the ones which have S and R enantiomers, and the S enantiomer, which is not, they're not racemic mixtures. The pure S types of ropivacaine and levobupivacaine. That's why they have reduced neurotoxicity and cardiotoxicity. Okay, moving on to the next question. The post-operative area supplemental oxygen should be given while recovering in obese patients. Read the assertion. Should we give oxygen? Yes. Then in the recovery room, the most common cause of post-operative hypoxia is due to loss of lung volume from small airway collapse and atelectasis. So you have two statements. To me, both appear right. So your choices now narrow down between option A or option B. Does the reason is actual reason for the assertion statement? If you feel that is the case, then option A should be your answer. But if you feel that the reason is right as a statement but doesn't qualify the assertion, then B becomes your answer. So it's narrow. It's easier to narrow down your thought process. But once you narrow it down, go back and read the two statements, and then arrive at your final answer. In this case, the answer is obviously option A or option B. Let me see how many of you have. So I'm actually prompting the answers for you. Saneesh, is that allowed? For the preparatory session, maybe it's allowed.
Yes, sure.
Because some of them will be getting sleepy now, so I need to speed up and then give them some amount of help cues. Yes, both assertion and reason are correct, and reason is the correct explanation of the assertion. Right. Option A, 83%. Good. Anesthetists are always vigilant, eternal vigilance. That's why most of them are answering it right. It's going to be about 9-10 in the night, but everybody is awake. Nobody wants hypoxia. Question 8, after total thyroidectomy, typical airway obstructive airway symptoms, whatever. Now, this question was deliberately placed here to wake you up and tell you that a similar question was given in the same section as question number 1. How many of you remember that? It is just for us to tell you that similar type of questions patterns can recur in the question paper. So you may actually go back, read this, and then it might answer that question number 1. And question number 8 by itself is a standalone question. So read, it's a long stem. You have to read all the aspects of it. And then you have to come to a conclusion after total thyroidectomy, the first statement or the second statement. It's a fairly common surgery, and most of you would have encountered problems with thyroidectomy. So option A or option B. So taking you back to hypocalcemia, parathyroid, devascularization, airway obstruction. I think all this Sreevidya had touched upon in the first question. So it may be a good idea for you to quickly jump back in the actual exam. You may be able to do that. And if you have a doubtful, if you have marked it, about 54% of you have said option A. What is the answer we have over here? Do you think option A is correct? Because in Dr. Sreevidya's first question, she had mentioned 10 hours after the surgery, patient actually has hypocalcemic symptoms. But here the option A says typical obstructive airway symptoms occurred immediately or only after about 24 to 72 hours. So you actually had an answer for this in the first question. 10 hours later, you had a problem. So if you have not factored that in, you will end up making a mistake. So in this case, the first statement is wrong. Second statement is correct because of these multiple issues which can happen after total thyroidectomy. This is just to sensitize you to the fact that some of the questions, answers which you may seek in one question might be there in something else. Okay, so we go to the question number 9. PADSS. We would actually not just give you abbreviations. We would try to give you the expanded forms because abbreviations can vary from place to place. We would give you the expanded form. In this case, it's a discharge scoring system. Now, assertion A, assessing patient's readiness for discharge. Assertion B, what are the criteria in PADSS? So let's check whether you understood this, and it's a straightforward factual question. You need to know what PADSS is. If you don't know, I would suggest you just skip this question. So the discharge scoring criteria says, assertion says it has got 5 criteria. And the reason second statement says it spells out all the criteria. So you need to match and figure out whether these 5 are exactly the 5 criteria which is a part of this discharge scoring system. But to be honest, if I would have got this question, if I didn't know, I would have marked it as both are right, and choice A would have been my answer. Because I feel that all the things are correct. Like most of you, about 60% of you have felt that yes, both are right, and the reason is the correct explanation for A. But did you read the last choice in of the 5 criteria in the reason statement? The last is ability to void urine after oral liquids. No, that is not a part of the PADSS. So it's important to test and be alert all through the exam and know your entire topic of what you're answering. If you're in any doubt, you don't proceed. And so here the assertion is correct, but the reason is an incorrect statement. All right, let's go to the 10th question. Syndrome X, metabolic syndrome. So the statement here says they have low levels of high density HDL, hypertension, increased plasminogen activity with inhibitor levels, and prone to coronary artery disease. And the reason statement says obese patients have insulin resistance leads to elevated levels of insulin and hypoglycemia. So read them independently, try to match them and see whether the reason statement is correct, whether the assertion statement is correct. So just giving you a helping hand, the reason statement, obese patients, insulin resistance. Resistance to insulin, so will insulin act? Levels will be high, but it won't act. So they will have hyperglycemia. So the statement itself goes wrong. So option C, and most of you have got the Q correct. More than 50% of you have answered it right. The reason statement is incorrect and the assertion statement is right. Be careful, sometimes the assertion statement also, but you don't have an option here to say assertion statement and reason both are wrong. Correct, Saneesh? You don't have an option that both are wrong.
Yes, yes.
So you can know very clearly that once you have identified one wrong statement, definitively the other must be a right statement. So it becomes easier for you to mentally come to a juggling attitude. All right, let's go to the next question. Do we have one more? Yes, identified the four people shown over here. Last question, and all your choices will be given.
No
full
whole
marks.
window here. Okay. Thank you very much, Aravind, Dr. Sreevidya and Dr. Suvarna for joining the preparatory session. I think all the 4 sessions were like a combined study with including faculty. Okay, it's been a learning process for us also. And I think we thoroughly enjoyed bringing these preparatory classes for you because we are generally not tuned to this objective type pattern. It's a new area, but it's something we need to explore because the career horizons are expanding and the selection test everywhere is likely to be going to the objective type questions where the coverage and the depth of knowledge will be tested. So
yeah, I guess most of them would have prepared for the European or the Australian or the American board exams. These are the patterns which they have to contend with. And the expected depth of knowledge is going to be quite broad and deep. So I think it's a fair enough idea for us to give them this kind of thing. And what do you think, Saneesh, has been the learning curve? Has it been a logarithmic increase in the terms of how the attendees have answered the section B and section C?
I think right now we need not be much concerned about how they answered because some of them were very casual. But I think in the coming days they'll become more serious about ICA Olympiad because April 2nd and 3rd, they have a chance to go for an mock exam, but unfortunately there won't be any scores offered after the test. But it's all depends on how much oriented the candidates are towards the kind of questions. I think we have tried our best to make everybody familiar with the kind of questions. Section A, single best response, +4 and -1. Section B will be multiple response questions. We have already explained the partial scoring. And section C, there will be 5 questions, assertion, reason, type. I think when we started, I thought assertion, reason, type will be very difficult. But now I think it's sort of easy, provided you are confident with the both statements. If you are not confident about either assertion or reason, then still a difficult one. But these are harder. Even
that's true, Saneesh. We had 10 questions this time.
Reason type, you are going to take away a maximum of 4 points. But the advantage is that 4 points will count the most when it comes to tiebreaker. People with same scores, those who score most on section C will carry more weightage. Then comes section B. And remember the third criteria, the faster you submit the exam, better will be your ranking among the same scoring candidates. Okay, ultimately it's only about peer group comparison, nothing more than that. It's a fun factor, but it's knowledge based. And remember the timeline we are proposing, between March 28 and April 1st, all the candidates should be getting the login credentials from our IT partner. So you'll be provided one user ID and a password, which should be kept confidential, should not share with any of your friends or delegates or other candidates. It's your responsibility to keep it confidential. And if you don't receive it by April 1st, April 2nd onwards, feel free to contact us through the WhatsApp number provided or the email ID. We'll be immediately responding because the same set of email IDs, I've requested all the candidates to verify their email ID and WhatsApp number because all our official communications will be through email IDs only. Okay, WhatsApp communication is for additional thing, but email ID is your proper communication. If you think it is not in your email inbox, make sure you check the spam folder as well, because without login credentials, you will not be able to take the exams. So how to clear that? April 2nd and 3rd, the platform will be open for all the candidates for a half-an-hour session. If you can log in there, yes, sure that you have received the credentials and you are using it comfortably. Make sure you are familiar with the exam portal. What are the facilities? How to keep the options for review later? How to submit exam? How to initially clear the system check? All those things. How to check your webcam, connectivity, microphone? How to do the screen share, everything we have shared the demo video. All the 4 sessions, what we have done for you, basically to make you familiar with it or to take you to this pattern of objective questions, all will be available on our ICA Academics YouTube channel. The links have been shared through our WhatsApp group. We actually wanted more of our candidates to come for our sessions live and share your thoughts clear your doubts, participate. But unfortunately, many are stuck with their duty responsibilities, academic responsibilities and all. But okay, we are providing the material. Feel free to use it. And April 6th is the most important day. The first session, the first ever ICA Olympiad is happening. The exam time is 10 a.m. to 12 noon. Remember, you need to join 30 minutes in advance so that you can clear all the initial formalities. Be cool. Even if you join at 9:30, everything, login, everything is done, cleared, system check, everything done. Be patient. Wait till to 10 o'clock. 10 o'clock, the clock starts. And exactly at 120 minutes, we'll stop the exam, and exam will be auto-submitted if you have not submitted the exam prior to that. There will be 100 questions, 120 minutes. This is the dynamics. There will be 70 questions in section A, 20 in section B, and 5 questions in 25 and 5. 70, 25, and 5. Section B and section C. And after the exam, 10 days break, April 16th, on our ICA webinar day on Wednesday, 7 o'clock, we'll all meet together. I request all the candidates to join the April 16th ICA webinar, where we'll be declaring the results. Of course, all the participants will be getting an e-certificate of participation, electronic certificate, on your email again. And the winners will be felicitated in our forthcoming national conference, ICACon 2025. So you are welcome to join. Even otherwise, we are welcoming everybody to join our forthcoming ICACon 2025. That will be in the end of August. The dates are already declared. The early bird registration is already happening. So welcome you for that. If any candidates, any delegates have any doubt, I'll enable your microphone. Dr. Smitharaj asked about the recording. Yes, recording will be provided. It's already provided. Only this episode will be pending. That will be uploaded maybe in a day's time. If anybody else wants to clarify something, please feel free to raise your hand. We are sure that actually we are placing an excellent panel of examiners to set the questions. So that's also ready. So we are ready to go for ICA Olympiad. We are waiting for the countdown, April 6th, the D-Day. With thanks to Dr. Aravind, Dr. Sreevidya, and Dr. Suvarna, it's over to Dr. Jayashree, so the President ICA, for the concluding remarks. Thank you.
Thank you, Saneesh. Yes, I'm sure that all the doubts have been cleared. There is no doubt about it. We've done it so meticulously. So thanks a lot for that. Thank you, Dr. Aravind, Dr. Suvarna, and Dr. Sreevidya for that participation today as faculty. It means a lot. And so students all set for April 6th. All the best. And then we shall be seeing you after that on the 16th of April again. In our webinar, and as Dr. Saneesh said, the prize winners will be called in August to Jodhpur. So all the best and see you soon. Thank you very much. Thanks a lot. Good night.
Good night.